will make the introduction. Namaskar, dear viewers. Welcome to today's special session of Critical Care Webinars International Faculty Day today. And today we are indeed honored, and it is a great pleasure to introduce Professor David Chiumello. Sir is Director, Department of Anesthesia and Intensive Care, AST Santi Paolo e Carlo, Milan, Italy. He is former editor-in-chief of the prestigious journal Minerva Anesthesiologica. And he has a huge number of publications, going over 500. And these are articles in critical care, in respiratory mechanics, in which he specializes, and ARDS. And he has published various guidelines and protocols. So we welcome you, Professor Chiumello, sir. It is indeed an honor and a pleasure to have you with us.
Okay, thank you very much, my friend. Good afternoon, good night. Here in Italy is around 4 p.m., so in the middle of the afternoon. So it's a great pleasure to give this webinar. So just start. I prepare some slide, and then after the talk, if there is time, we can discuss a little bit. So the topic is lung mechanics. So it's a huge topic, and I would like to focus regarding ARDS, so the most severe form of acute respiratory failure. And when ARDS was born more than 50 years ago, in 1967, and ARDS was described in a short paper. And look here, 12 patients. And
you have to share the slides.
Can you see my screen?
I cannot see right now, sir.
I share again. Now it's better.
Yes, you have to go full screen, sir.
Okay.
Great. It's gone again, sir.
Sorry. I try again.
Yeah.
Okay. Give me. Okay. Now I think it's working.
Yeah, yes, sir.
Okay. So the first description of ARDS was published in 1967 in 12 patients. And what were the characteristics of this patient? They present an acute respiratory distress. They present cyanosis refractory to oxygen therapy. They have alteration in the mechanical characteristics, so they have a decrease in the lung compliance. And another important point is that at chest X-ray, they present a diffuse infiltrate. And by moving from that time, now we arrive in 1997, Peter Sutter, that was one of the pioneers of intensive care medicine, like Luciano Gattinoni, that unfortunately died last year, described the different stage of ARDS, an early and a late phase. In the early stage of ARDS, there is an increase in a pulmonary edema, and two types of pulmonary edema, interstitial and alveolar, and there was also an associated increase in inflammatory reaction, increase in permeability, and in alteration of respiratory mechanics. This was the last consensus conference, the Berlin's definition, that was released more than 15 years ago. And not too much was changed comparing the first description. One of the most important points is the characterization of the severity of the ARDS. Now we have three well-described types of the ARDS: mild, moderate, severe, according to severity of gas exchange, and associated with the presence of pulmonary opacity at the chest X-ray, at the onset should be within 7 days. And to describe patient with ARDS, there is at least a minimum level of people regarding 5 centimeters of water. But what is ARDS? ARDS is a syndrome. So we have different etiology that can develop at the end a manifestation of ARDS. And what are the mainly common reasons? Look here, the majority of the patients present with sepsis. And inside of this big umbrella, we have ARDS to, for example, to bacterial pneumonia, viral pneumonia, aspiration pneumonia, and also patients with sepsis. So the problem that we have is that by describing in a whole population ARDS, they present different behavior, different respiratory mechanics, different alteration in gas exchange, different alteration in the space, in this alteration at CT scan. This is a typical CT scan of a patient with ARDS in the early phase. And as you can see, it is very clear that ARDS is diffuse disease by a different alteration in the different part. Usually in the upper part, there are the also called the normally lung part, in which there is not any alteration in the gas exchange, and this is typical appear at CT scan like black. On the opposite, we have the white area of the lung, which has completely collapsed, consolidated, in which there is no ventilation. So this part of the lung does not participate into any form of gas exchange and any form of alteration of respiratory mechanics. The third part of the ARDS is the presence of the poorly aerated lung, which is an intermediate phase between the normally aerated and the not aerated lung. Then we have also the presence of pleural effusion, typically at the onset of ARDS. This is not a problem. So we have to focus in these three parts: the normally aerated part, the poorly aerated part, and not consolidated part. So by applying the quantitative analysis from an original idea of Professor Gattinoni, it was possible to have and to compute how the lung is constituted. So look here, we have patient with normal lung underwent general anesthesia and patient with ARDS. So with the quantitative analysis, it's possible to exactly assess the amount of the gas and the amount of the tissue. The gas plus tissue constitute the size of the lung. So what's happened in patient with ARDS compared to patient without ARDS? By moving from the ventral to the dorsal part, so for the mediastinum going to down, there is a significant increase in patient with ARDS, the black bar, in the amount of the tissue, so compared to patient with healthy lung. So what does suggest? This suggests that the alteration in permeability, the increase in the edema, is mainly localized in the lower part of the lung. The increase in the amount of the tissue significantly decrease the amount of the gas. So, and comparing to healthy subject, the total size of the lung is not different. What is the difference between ARDS and healthy patient? Is the amount of the weight of the lung. There is a significant increase in the weight of the lung due to increase of the edema. So the idea is that the lung behavior has a sponge, so in which the sponge increase the weight due to increase the amount of the water, amount of edema. So the superimposed pressure, which is the product of the height of the lung and the density, is significantly increased compared to patients with normal lung. For the same height, so for the same anatomical position, the superimposed pressure significantly increases by moving from the mediastinum to the dorsal part of the lung. And for the same height of the lung, the superimposed pressure is significantly increased. So what this cause into the lung? Just to summarize, we have the normal rate region in which the opening pressure, so the pressure that we have to develop by the mechanical ventilator to inflate the lung is quite low. When we have applied the higher pressure, we have to apply in presence of the alveolar collapse or in presence of consolidation, and higher is the amount of the alveolar collapse, higher are the pressure required to inflate the lung. And finally, if we have a consolidated part of the lung, typically patient with pneumonia, pneumococcus pneumonia is a typical lobar pneumonia in which there is alveolar consolidation. So, my friend, it's not possible to recruit this part of the lung because it's consolidated. We can only recruit the lung in ARDS lung in which there is alveolar collapse. And higher is the amount of the alveolar collapse, higher is the pressure required to inflate the lung. So by moving from ChatGPT, I put the monitor of ARDS. What ChatGPT suggests? So ventilatory parameters that we have to monitor is the tidal volume, the PEEP, the respiratory rate, but also the lung mechanics. Look here, point 4. Monitor lung mechanics requires the assessment of the lung compliance and the resistance. What we have to look at the plateau pressure, mainly the higher plateau pressure, the driving pressure, and respiratory system compliance. Why? Because this can give you individual information regarding the lung function and help to guide the ventilatory management strategy tailored to patients with ARDS. Try to summarize how is the respiratory constituted. The respiratory system is made by the lung and by the chest wall. So every time we inflate the lung, we also inflate the chest wall. The lung and the chest wall are in parallel. And the pressure that we have to use to apply is to overcome the elastic property of the lung and the chest wall, and mainly the respiratory resistance into the lung. This is a typical stream of the ventilator in a patient during anesthesia or in patient with ARDS. This is the inspiratory flow. This is the higher pressure. So this is inspiration. This is the positive inspiratory flow. During the inspiratory time, there is a constant inspiratory flow. During the expiration, there is a reverse. If we perform a pause, so a static condition, we can assess the driving pressure. The driving pressure is the difference between the plateau pressure and the PEEP. So it's the pressure required to maintain inflated the lung. But during the inflation, the higher pressure is significantly higher compared to plateau pressure. Why? Because this pressure is used to overcome the higher resistance. This is just a few examples how the lung mechanics can significantly affect the waveform that you can get by a simple visual analysis from the ventilator. We have normal condition, constant flow. During expiration time, this is a typical, regular, and normal curve. In presence of high resistance, During expiration, you can see very well a reduction in the peak expiratory flow. Low compliance, you have on the opposite a very high peak expiratory flow, a very short expiratory time. So, my friend, it's very important to understand what is going on the ventilator by just simple analyze the waveform. So increase in the high resistance or alteration in the compliance. So I move on. Oh, what is the compliance? The compliance is defined as the change in volume per unit change in the delta pressure. The reverse of the compliance is the elastance, is the change in the delta pressure per unit change in the volume. I prefer to assess the respiratory mechanic according to the elastance. The elastance of the total respiratory system is equal to the sum of the elastance of the lung plus the elastance of the respiratory system. On the contrary, by using the compliance, you have to use the reciprocal, so it's more difficult. Compliance, respiratory system, compliance of the lung, compliance of the chest wall. Compliance is the ratio between the tidal volume, so the inspired tidal volume, to the delta pressure, so the difference between the static pressure at the end inspiration and the PEEP. If you want to assess the lung and the chest wall, we have, my friend, to estimate the pleural pressure. And the easy way to estimate the pleural pressure at the present time is using the esophageal balloon. By putting an esophageal balloon in the lower part of the esophagus, it's possible to estimate the change in the pleural pressure. And by using this value, you can assess the lung compliance, which is computed as the ratio between the tidal volume and the difference between the driving pressure and the esophageal pressure from end inspiration to end expiration. Finally, the chest wall, we have two options. If we assess the total respiratory compliance and the total respiratory elastance and the lung elastance, the difference between the two is the chest wall. According to this equation, tidal volume divide again to the difference in the pressure from end inspiration and the expiration. And here is the elastance. So when we have to assess the lung compliance. The lung compliance is indicate how stiff is the lung, and compliance is related to the amount of the lung which is ventilated. So don't make the error stating that compliance reflects the not aerated lung of the lung. The compliance reflects the ventilated part of the lung. To distend the lung, we have to apply a change in pressure. And by focusing only in the lung, the pressure which distends the lung is the transpulmonary pressure, which is the difference between the airway pressure and the esophageal pressure. The transpulmonary pressure reflects the stress. So the stress is a pressure. The strain is a deformation is related to the tidal volume compared to the functional residual capacity, so to the size of the baby lung, which is the link between the stress and the strain, so the pressure and the volume. Very simple. The transpulmonary pressure is equal to the stress, to the strain, and to the specific elastance. The stress induces the barotrauma, so one possible form of the VILI, the ventilator-induced lung injury. The strain induces the volotrauma. We can assess at bedside the stress of the strain, and by having computed the stress of the strain by the specific elastance, we can assess very easy the stress or the strain. Unfortunately, at bedside, it's very difficult to measure the strain, because if you don't have a helium dilution technique or CT scan, the functional residual capacity we cannot assess, so we cannot assess the strain, while the stress is more easy. And why it is important to evaluate the stress, so the transpulmonary pressure. Focus on the right part of this figure. This was a group of patients ventilated with different tidal volume, different level of PEEP, in which we simultaneously measure the higher pressure and the transpulmonary pressure. Look here, for example, 30 centimeters of water of higher plateau pressure, which is a typical, now, the cutoff to not overcome. So now it's not 30, but it's between 26 to 28. But anyway, for the same higher pressure, the patient with ARDS can present very different transpulmonary plateau pressure. The transpulmonary plateau pressure can be 24, for example, up to 12 centimeters of water. So a huge range. In clinical practice, we can have two patients with the same inspiratory higher pressure, so the same static pressure, but with very different transpulmonary pressure. This is better represented. Inspiratory higher pressure, 30 centimeters of water. Two types of patient, type 1, type 2. Type 1, patient with a very stiff lung, very high elastance of the lung. Type 2, not very much increase in the elastance of the lung, but a significant increase in the elastance of the chest wall. And finally, for the same end inspiratory higher pressure, the transpulmonary pressure was significantly different. And in which case the transpulmonary pressure was higher? Was higher in patients in which there is a higher impairment of the characteristic of the lung compared to the impairment of the chest wall. So in terms of ventilator-induced lung injury, it is more dangerous patient with an increase in the elastance of the lung compared to increase of the elastance of the chest wall. So again, the stress and the strain, we already defined. How is possible to compute the lung stress? The lung stress can be computed in different way. Can be the product of the higher pressure, so the pressure that we can read from the screen of the ventilator, and the ratio between the lung and the total elastance. The product of these two components gives you the lung stress. The specific lung elastance, so the link between the stress and the strain, is quite constant among patients with ARDS. What does it mean? It means that the ventilated part of the lung presents a similar characteristic in patients with ARDS compared patients without ARDS, which here is very clearly represented the strain and the stress. By increasing the stress, this was associated to increase to the strain. When you have a transpulmonary pressure of 12, we have the lung strain of 1. What does it mean? It means that the tidal volume is equal to the functional residual capacity. The ratio is 1. By moving from 12 to 34, 20, 38, this was associated to increase in the lung strain and possible risk and power trauma, pneumodiastino, pneumothorax, subcutaneous emphysema. Another important point is the size of the baby lung, so the amount of air which is present at the end of expiration in presence of PEEP or without PEEP. This is clearly represented in this figure, the body weight, ideal or actual body weight, and the total lung gas volume. And as you can see, unfortunately, it was not found any relationship between the two. So the idea to apply a tidal volume of 6, 8, whatever you want according to the ideal body weight does not any physiological sense in patients with ARDS, because the sites depend not only on the body weight, but on the severity of the ARDS. A good relationship between the lung gas volume of the lung and the body weight was found in patients without ARDS, in which higher is the height, higher is the weight, higher is the size of the lung. But in ARDS, this relationship does not work. Another important concept is the recruitment. The recruitment is the amount of tissue which is not ventilated that became ventilated. So it is an aeration of pressure gas lung region. By CT scan is very simple to understand because we have an atelectasis or collapsed lung region which appear white, that by recruitment over, by putting prone, by increasing tidal volume, by increasing the opening pressure, this became aerated. Inflation, on the contrary, is just the further aeration of already inflated lung region. So is good is the recruitment that can reduce, for example, the ventilator-induced lung injury. The inflation can promote an overdistension, so it's not good. But how much is the lung recruitment? In this study, we perform CT scan at two levels of people, low and high. And we measure the recruitment, so a decrease in the amount of not treated area by passing from a low to high level of PEEP. In the right part, there are two typical patients. One patient in which, you see, was defined, so a patient with a low amount of potential recruited lung, because the white part of the lung does not change in the size. Type 2 is a patient with a very high potential recruited lung. Look here, very large amount of white lung, which becomes black, similar to the normal red lung. Same higher pressure, different amount of the baby lung and size of the consolidated atelectasis lung region. Another important point is that every time you increase the PEEP, you have an hemodynamic effect. Look what happened. The heart is completely squeezed by increasing the PEEP. And how much is the recruitment? Is around 10%. This was the average in the whole population. This was up to 60, 65 patients. 10% was the potential recruited lung. If you remember that the weight of the lung of patient with ARDS is around 1.2, 1.3 kilogram, 10% means 100 grams of tissue, which is possible to recruit by applying a PEEP of 45. So high level of PEEP, a lower amount of potential recruited lung. Not all the patients have a same behavior. This was the recruitment lung tissue, and this the pressure that was applied. In red is represented patient with the most severe form of ARDS, PO2 FO2 ratio lower than 100. In green, patient with a moderate form. Patient with a high severity of the ARDS, for the same amount of applied pressure during recruitment maneuver, present a significantly high amount of lung which is recruited. And the second important point is that it is unuseful to apply a higher pressure, higher than 35, 40 centimeters of water, to get a high amount of recruitment. This did not happen. By increasing the higher pressure, the amount of lung which is recruited was very low. But what are the evidence and the message that come from the several randomized controlled trial in which, according to the theory of ventilator-induced lung injury and respiratory mechanics, this could significantly affect the outcome. So if you have two patients with the same mechanical characteristic and we apply different type of mechanical ventilation and the outcome will be different, the only explanation is the different iatrogenicity of the mechanical ventilation that was applied in this population. And what are the possible, mainly determinants? Tidal volume, This was one of the most important studies. It was published in 2000 here, in which for the first time in a multi-center randomized study, the application of the tidal volume of 6 ml per kilo compared to 12 ml per kilo, according to the body weight, with a similar level of PEEP and a different plateau pressure, was able to modify the outcome when the patient presented a bad outcome. Patients who were ventilated with the 6 ml per kilo compared to 12 ml per kilo. But the step forward is that for the same tidal volume, according to the different size of the baby lung, the final effect can be completely different. The driving pressure is the ratio between the tidal volume applied from the mechanical ventilator from the physician and the compliance for the respiratory system. And why it is important? Because it's a combination. I can have in the two patients, type 1 and type 2, the same tidal volume, but for the different severity of the disease, the compliance is different. So the resulting driving pressure can be significantly different. And this can help to understand the severity of the alteration in the respiratory mechanics. The driving pressure is possible to estimate also during assisted mechanical ventilation, but for a good value, you have that the patient deeply sedated with or without paralysis. And what is important? Because higher is the driving pressure, higher is the mortality, and seems to be a range. A driving pressure lower than 12, 30 centimeter water did not deteriorate the outcome. A driving pressure higher than 40, 15 significantly increase the mortality. So now we have to put together to this concept tidal volume, driving pressure, and PEEP. Before the theory of the ventilator-induced lung injury, patients were ventilated with a very high tidal volume to here, with the risk of alveolar overdistension without application of PEEP, alveolar collapse. So end expiration, overdistension, and expiration collapse. So think how many times per hour per day this dramatically increase the risk and the development of the VILI. By moving from this concept, now we apply low tidal volume compared to very high tidal volume and PEEP. So PEEP can prevent the recruitment, the athletic trauma, with the tidal volume, which can reduce the possible overdistension at end expiration. But remember, by maintaining the same tidal volume, every time you increase the PEEP, you increase the risk of overdistension because you move from here to here. You can reach, by maintaining the same tidal volume, just by increasing the PEEP, the red zone. Tidal volume PEEP are always linked, are not separate. It's an error. to deal with PEEP and with tidal volume. We have also, but the really existed. Yes, my friend, this was a quite recent study in which the author, the initial hypothesis was that an aggressive protective mechanical ventilation with adequate level of PEEP to decrease the risk of athletic trauma, and by applying a very strong lung recruitment strategy, could improve the outcome. But unfortunately, the results are completely opposite. The group of patients who underwent lung recruitment and PEEP present a significant worse outcome compared patients treated with low level of PEEP. And higher is the plateau pressure, or higher is the driving pressure, higher is the mortality rate of patients with ARDS. Just 2 words, because every time we speak about mechanical ventilation, respiratory mechanics, we forgot, in my idea, 2 main aspects. The CO2, the role of that space. Today I have no time, maybe next time we can speak about the ventilatory ratio of the dead space and the possible change of the dead space as a monitoring of the ventilator-induced lung injury. And third point, every time you apply PEEP, my friend, you increase the oxygenation. 90% of the case, you have a patient with hypoxemia. Just by increasing PEEP, you increase the oxygenation. But the problem is not the oxygenation, it's not the hypoxemia, is to avoid hypoxia. And this was the effect of changing PEEP on the oxygenation, shunt, compliance, and the decrease of cardiac output. So you're happy, you have a patient, you increase the PEEP, your oxygenation goes up. The compliance increase, but the delivery of oxygen decrease. So this patient can simply suffer of hypoxia. So we have to personalize mechanical ventilation by look tidal volume, driving pressure, esophageal pressure, lung imaging, and gas exchange. This was one of the Gattinoni statement in which he always suggests to use the brain before to set to play with the ventilator. You must first connect your brain. You must understand the pathophysiology, the alteration of the lung mechanics in terms of the stress, strain, driving pressure, plateau pressure, lung recruitability. Point C, to rest and protect the lung. So we have to avoid the ventilator-induced lung injury. Now, today, we are focusing about the controlled mechanical ventilation, not assisted mechanical ventilation. So all the concepts that I share with you are true. You can apply in patient with ARDS, but in controlled mechanical ventilation. So in the first part of the disease, in the early phase in which controlled mechanical ventilation is usually applied. Let me check the time. Okay, so we have 10 minutes. This was one of the most important equation is the motion equation, in which if you have a patient ventilated, so the patient receive a certain amount of pressure by the ventilator and the certain amount of pressure generated by his own muscle. If the patient is paralyzed, the muscle pressure is not present. So we have only the pressure developed by the mechanical ventilator. And why? And what are the consequences? And in which form is used this pressure? Is used to inflate the respiratory system, so to generate a certain amount of tidal volume according to the respiratory characteristic of the lung, the elastance of the respiratory system, to generate a certain amount of the flow, which depend again on the resistance of the highway. And the third part is not the case of patient of ARDS, is the intrinsic PEEP. Why it is important to understand the respiratory mechanics? This was one of the first study, maybe my knowledge may be the first, in which by putting esophageal balloon, it was analyzed the different condition of the ARDS, pulmonary or extrapulmonary ARDS. Pulmonary is typically ARDS generated by bacterial pneumonia. Extrapulmonary, patient with peritonitis. And what happened by changing the level of PEEP? A very different behavior. The elastance deteriorated by increasing PEEP in the pulmonary ARDS. And the elastance of the chest wall was significantly lower compared to the elastance of the lung in the pulmonary ARDS. In the extrapulmonary ARDS, peritonitis, the chest wall elastance was quite similar to the lung elastance. And by increasing the PEEP, the elastance of the lung decreased. What does suggest? Suggests that the respiratory mechanics, the measurement and the assessment of the respiratory can help you in the daily clinical practice. If you don't have an esophageal balloon, you can very simple have an idea regarding the pulmonary and the extrapulmonary effect. This was a recent study in which we analyzed two groups of patients, pulmonary and extrapulmonary. Pulmonary ARDS present pneumonia, extrapulmonary ARDS present sepsis. No different in the outcome, but in the intra-abdominal pressure, significant difference. Patient with extrapulmonary ARDS present a higher intra-abdominal pressure different behavior in gas exchange. Pulmonary ARDS compared to extrapulmonary ARDS for the same level of PEEP, 5 and 15, present a significant oxygenation. And in which group the oxygenation was worse? Pulmonary ARDS compared to extrapulmonary. But in the both group, by increasing the PEEP, the oxygenation increased. The lung recruitability was different in pulmonary and extrapulmonary ARDS. Just a few words. I'm going to finish, so we have some minute of discussion regarding the possible component of the ventilator-induced injury. This was again the motion question. The possible determinant of the damage to the lung, the physical damage of the lung, are the tidal volume, the driving pressure, the PEEP, the respiratory rate, and the size of the lung. And to have an idea regarding how this component generate the damage to the lung, we have to compute the mechanical power. The mechanical power is the product of the volume and the pressure generated breath by breath, taking into account respiratory rate. Tidal volume is the dynamic component of the mechanical power. The resistance is the second component of the dynamic mechanical power. Then we have the PEEP, which is the elastic static component. And why it is important, my friend? Because here is the change in the mechanical power according to the different component: tidal volume, flow, driving pressure, respiratory rate, and PEEP. Is much more important the increase in tidal volume or driving pressure compared to change of PEEP or respiratory rate. So the same change in terms of percentage, tidal volume, respiratory rate, or PEEP can have a very different consequence in the mechanical power. I'm going to finish. So the calculation of the mechanical power during control mechanical ventilation is very simple. What we need is the respiratory rate, tidal volume, peak inspiratory pressure, plateau pressure minus PEEP, doing volume control mechanical ventilation. If you are using pressure control mechanical ventilation, it's much simple. You just need the respiratory rate, the tidal volume, the PEEP, and the driving pressure. So remember, two different equations according to the type of mechanical ventilation. So this was the last slide of my presentation. We have to look in all parts of the patient. Unfortunately, in this 1 hour seminar, I just focus on the lung mechanics. Now, since today, we have to measure and to assess by looking the graphs of the mechanical ventilator. We can assess the compliance, the elastance, or the resistance. We can assess the pleural pressure with esophageal balloon or by measure the intra-abdominal pressure. And the other point is the assessment of the mechanical power. Thank you very much. And I congratulate
Thank
all the
you very much.
physicians.
Thank you very much, Professor Chiumello. Sir, lovely presentation, much to learn from it. So, sir, can we take a few questions for discussion?
Sure, my friend, sure.
So I request the audience also to type any questions if they have. So, sir, just about the stress. So you showed one slide on stress, and you said that it is approximately equal to the transpulmonary pressure, but it is not the same. So what is the difference between stress and the transpulmonary pressure?
Now, the transpulmonary pressure generates the stress. So the transpulmonary pressure is the way to compute the stress. The stress and transpulmonary pressure are equal. Okay, if you want to assess the stress, you have to assess the transpulmonary pressure.
Right. Thank you. So then you showed mechanical power in the end. Now, just want to know what is the latest development in terms of normalizing mechanical power, because mechanical power, I believe, more than 17 joules is supposed to increase mortality. But then mechanical power of 70 in a small lung is different from mechanical power in a big lung. So has there been any normalization? That is the first part to that. Second part is there has always been some controversy regarding the power required to move the flow across the airways and the component of PEEP. So what is the latest thinking on this, sir?
Yeah, very good question, my friend. So regarding the normalization of the mechanical power, we don't have, or I don't have a clear answer. Of course, if we have two patients and we apply the same mechanical power, but the size of the lung is different, maybe the final effect of the mechanical power, so the intensity which is transmitted into the respiratory system, is quite different. There are some papers in which they try to understand and to make a normalization of the mechanical power. This can help, of course, and can give more precise data. So according to the size of the baby lung, according to the compliance, according to the status of the patient. Regarding different components of the mechanical power, again, there are no clear data. So for example, I can have the same mechanical power, but obtained by different conditions. High tidal volume, low respiratory rate, for example, or low tidal volume, high respiratory rate. Seems to be, at least in animal experiment, that for the same mechanical power is much important to the dynamic component, so the tidal volume. There are not some good data regarding the resistance. So the size of the tidal volume. The PEEP depends on the effect of the compliance, because sometimes seems paradoxical, but you increase the PEEP, but the mechanical power decrease. Why? Because you have a recruitment. So the driving pressure goes down. So you increase PEEP, driving pressure goes down, mechanical power cannot change or can reduce. So depends, and you have to tailor in each patient. And the third point, then I go to, is the hemodynamics. Is the hemodynamics. Please remember hemodynamics. Every time you change the mechanical ventilation, you increase the mechanical power, you increase the PEEP, you affect the hemodynamics. Maybe next time we will deal about also with this topic.
Thank you, sir. So then moving on to the concept of airway closure in ARDS. So this is a relatively new concept, a few years only it has been there, and 30% of the patients in ARDS are supposed to have airway closure. And once you have airway closure, you don't get the correct plateau pressure. So what trials were done before this? Did we have the correct plateau pressure? First question. Second question is, how do you detect it at the bedside, and how to actually go about setting PEEP and managing the ventilator settings when you have airway closure?
Yeah, this is the airway closure is a problem if you assess the recruiting inflation ratio. So there seems to be in a certain amount of patient a certain level of higher pressure in which there is no change in volume. And then by overcome this point, the lung start to inflate. So by performing CT scan at two levels of PEEP and assessing lung recruitment is not a problem. If you use the recruitment inflation ratio suggested by Dr. Borchardt, you have to exclude the possible pressure of occlusion pressure.
Right. Thank you, sir. So then another question is about the transmission of the alveolar pressure to the pleura. So you have different lungs. You have a normal lung, you have a ARDS lung, you have a COPD emphysematous lung. So the transmission of pressure from the alveoli to the pleura is different, right? In a normal lung, it is supposed to be approximately half the pressure, alveolar pressure. In ARDS is very little, less than 20%, and in emphysematous lung it is almost about 80% of it. So what is the difference here? The transmission of alveolar pressure to the pleural pressure in different conditions.
Yeah, I completely agree. Depending of the stiffness of the lung, depend is the mainly consolidated, collapsed, if there is interstitial problem, alveolar problem. So it is not possible to predict. You have at the bedside to evaluate in each patient.
Right, sir. Thank you, sir. So then a question on COPD, sir. We discussed ARDS, but just COPD because this is lung mechanics. COPD is big time lung mechanics. So we have these patients, sir, who are not coming off the ventilator, right? You have done everything. They're not getting weaned and extubated, and 1 week has gone by, 2 weeks have gone by. So what factors in lung mechanics in these COPD patients help us to prognosticate that they'll be requiring long-term mechanical ventilation or may not come out from the ventilation?
So is subset of COPD which have ARDS. So the presence of bilateral disease. So my suggestion is at admission to perform a CT scan, perform a PEEP test, two level of PEEP, evaluate the possible presence of increase in the resistance, out of PEEP, the driving pressure, tidal volume, so you can have a whole idea and you can focus on the main problem of this patient. Is the resistance problem, is the compliance problem, is the impairment of gas exchange, is the ventilatory ratio problem. So by having this data, then you can have an idea regarding, for example, the days of mechanical ventilation, the outcome, maybe the need of tracheostomy, if the need of composition, or otherwise by moving from controlled mechanical ventilation to assisted mechanical ventilation. So more data you have, more easy is to treat the patient. And not treat the number, treat the patient. My friend, treat the patient.
Thank you. Then, sir, last couple of questions only. So about driving pressure, you talked about driving pressure. So driving pressure is a statistical derivation based on the assumption that the volume should be normalized to the compliance, since compliance is proportional to the baby lung rather than normalizing volume to the ideal body weight. And that was the basic assumption, and that is what we got from the analysis, the statistics that were applied to it. But how do we understand this as a concept, driving pressure?
No, I completely agree. The driving pressure add the concept of the size of the baby lung. So the compliance is related. There is not very good, but there is a relationship between the size of the baby lung and the compliance. This was nice shown from one of the first study of Gattinoni. So in that particular patient, maybe you cannot have a good relationship because if you have, for example, impairment of the chest wall compared to the lung, you cannot find good relationship. On the contrary, in the patient with much impairment in the lung, the relationship could be quite good. But one of the advantages diving pressure that is very easy to measure at the bedside. So just to do a pause during mechanical act and you obtain the diving pressure.
Thank you for the answer. Final questions, simply in what patients, in what disease sets, in what conditions can we go up to a tidal volume of 8 ml per kg or maybe even more if required? Can we, is it okay to go that high?
Yeah, I'm not scared to use 8, 9 ml per kilo, depending of the compliance, the size of the baby lung, the amount, and for example, if a patient have emphysema, there is no problem to use a very high tidal volume. The tidal volume per se does not mean anything. You have to compare, for example, to the size of the baby lung, to the strain. I make an example. You have very severe ARDS, which has an end respiratory lung volume of 500 ml, and I ventilate with 500 ml. So the strain is 1. I have in the other bed patient with emphysema and ARDS. The end respiratory lung volume is 2 liters. I ventilate with the same tidal volume, but the strain is completely different. So in my opinion, the tidal volume per se does not mean anything. Just give an idea. But in that particular patient, you have to look to the size of the baby lung. And if you don't measure the end respiratory volume, measure the stress. Otherwise, you don't understand anything about the mechanical ventilation.
Right, sir. Thank you so much, Professor Chiumello, sir. Really grateful and honored to have you with us and talk to all of us. So many people have joined, and we'll be putting this up on our YouTube channel for the entire global community of intensivists, especially the young ones, to learn from. Really, thank you. Thank you very much, sir. And goodbye and ciao, sir.
Goodbye. Goodbye from Italy. Bye-bye, my friend.
Bye-bye. Thank the audience, namaskar, for joining in such large numbers. I hope you had a good time. Thank you, everybody. Good night.